It's the top of the hour, but we're going to go ahead and give everyone 1 or 2 more minutes to log in. Good morning, everyone. My name is Sarah Meany-Rod. We're going to go ahead and get started, but there might be a few people that log in as we get going here. I am the PBRN coordinator with DO-Touch.NET. Thank you all for joining us for this month's episode of Let's Talk About OMM Research. Before we begin, let's talk about the housekeeping rules for the webinar. Please add your name and location into the chat for accreditation requirements. If you have registered for CME credit, you must add your name in the chat to verify your attendance in order to receive CME credit. Additionally, you will need to complete the physician attestation form, which was emailed to you this morning, and an evaluation survey, which will be emailed to you this afternoon. The Let's Talk About OMM Research Planning Committee has no conflicts of interest to disclose. If you have any technical issues during the webinar, please send a message to me or Jane Johnson. If you have any questions or comments during the presentation, please feel free to type them into the chat and to address each other's comments and questions there as well. After the presentation, we will have time for discussion and questions. If you would like to speak during the discussion, please raise your hand and we will unmute your microphone. We ask that you briefly introduce yourself and feel free to turn on your camera if you would like. When contributing to the discussion, please limit microphone time to 3 minutes to allow for everyone who wants to participate in the discussion. Please keep in mind that this webinar is being recorded and will be placed on the DO-Touch.NET website, where you will have the opportunity to continue the discussion. Please watch for an email from DO-Touch.NET announcing when the recording and discussion forum are available. Now, please help us welcome Dr. Nicole Bixler, who will be speaking about value-based care in osteopathic medicine. Dr. Bixler graduated from Philadelphia College of Osteopathic Medicine in 2002 and completed her family medicine residency in 2005 at Frankfurt Hospital in Philadelphia. She is a clinical associate professor at Dr. Kiran C. Patel College of Osteopathic Medicine at Nova Southeastern University, as well as a core faculty member for the HCA Family Medicine Residency. Finally, Dr. Bixler is the past president of the Florida Society of the American College of Osteopathic Family Physicians, Florida Osteopathic Medical Association, and the American College of Osteopathic Physicians. There are no conflicts of interest to disclose. Please help us welcome Dr. Nicole Bixler.
Great. Thank you. Thank you very much. I'm going to go ahead and share my screen. Hopefully everybody can see that okay. Thank you for that warm welcome, Sarah, and thank you for everybody's involvement in making this happen, particularly Dr. Degenhardt, who I met well over a year ago, and we started initial discussions in me being able to present to this group at some point in time. So Sarah's already taken care of some of this stuff for me. So certainly the
Actually,
goal of
Nicole, I don't think we're seeing your screen.
you're not seeing it? Okay, well, let me try again.
Sorry.
Are you seeing it now? Or no?
Nope,
I'm
not
not.
yet.
Who is?
We're not seeing it yet, but I know we just tried this, so I know
We
it
just
works.
did it right before we started. So let me try it again, see what the problem is here. Let's see. Let's try it one more time and see why it was not working. Okay, let's try one more time. Apologies, right? We did a dry run to make sure we wouldn't have this problem. So
There we go. Now it's
see now?
working.
Okay, sorry about that. Okay. We're all good. That was the first, but now it's not letting me advance. So that's the problem here. There we go. Okay, now I just have to get back though. There we go. Sorry about that. All right, the first couple slides were fine because Sarah already did all that work for me, and that was introducing myself and letting you know I have no conflicts of interest in presenting this to you. Again, as I said, this is something we've been kind of talking about for well over a year, and it really spawned out of the discussion when I met Dr. Degenhart in person when we were at a meeting in Maine, and it was about what I do every day in my office, and that is I practice in a value-based care model of medicine. And so I'm going to try to present to this group a little bit about value-based care in case there are those who don't really know all of the facets of what is part of value-based care, those models, and then certainly how specifically do I see that as correlating with osteopathic medicine, and then hopefully opening up some avenues of what else could we do, particularly maybe with some of the people on this call as to what other research could we do in osteopathic medicine to correlate the value of it within a value-based care model. So excuse me, I'm getting over a little bit of an upper respiratory, so voice a little scratchy. So first of all, what is important to me? Well, certainly providing well-rounded primary care that utilizes all my skills that I learned as a osteopathic family physician resident and what I continue to do every day in my current practice. Certainly by my bio, I think you can see I'm an advocate for our profession. I truly believe in osteopathic family medicine. So it's always been critical for me in my 20 years of practice thus far is to be a part of leadership and education, particularly of our future physicians. I am a mom of 3 girls and married to a family physician as well. We work in the same practice, so maintaining a balance of work and home life and being a role model to my girls as well as to other female physicians has also been critically important to me, which is quite nice that today is Women's Equality Day. So I think it's like a perfect day for me to be presenting that and be able to say that. So so my background, you already heard that, so I don't have to go over any of that, but I really do, the reason why I speak on this topic is really clearly because I've practiced in a value-based care model for 15 years. And during that time have taught students and residents along the way and been able to do all the other things in our profession. And I think it's allowed me to do that because of the type of model of medicine that I practice in and because of my osteopathic training. So just a quote here that I found sort of interesting, putting healthcare consumers in charge, letting them determine what is valuable is really a radical reorientation from the way the American health system has worked over the past century. I think many can agree that the current system might work for many, but it does not work for everybody. We have vast deserts of care that are just not being addressed. And it's sort of that same adage, if you just keep doing the same thing, you're going to keep getting the same results, and that's sort of insanity. So something's got to change. And certainly there's been lots of different options presented, lots of different thoughts on that. But, from a big government standpoint, not only is it not working for patients, it's not really working for taxpayers. We pay a ton of money for our healthcare, and we're not really getting the good results. So what is value-based care? Value-based care is a program that is really trying to reward healthcare providers with incentives, payments for the quality of care they give to patients, not the quantity, but the quality. And I think that's critically important. I think that's what has really been missed in a lot of healthcare. And it's really tough because we all can agree there's a shortage of healthcare providers, particularly after COVID. So it's really hard to sometimes say, well, someone's got to work on the quantity, right? We can't all just look definitively for quality, but if we're not giving quality care, then somewhat what is the purpose of that care? So These programs are really spawned by CMS looking for strategies to reform how healthcare is delivered and paid for. And the theory is really to address the quadruple aim: better care for individuals, better care for the overall population, lower cost, and also to improve the care team's experience, the doctors, the providers, the nurses, everybody that's a part of the experience, to give that better quality of life, that better balance, as I mentioned, that is important to me. So how do I find that to be very similar to our osteopathic principles? So when I look at it as a big global thing, I sort of thought, well, you know, we have our trilogy: mind, body, spirit. So when I think about the mind, I think of that's better care for the individual. And then when you think of the greater body, that's better care for the entire population. And the spirit of it is we're trying to do it in a lower cost way, but with good quality. And so I really think that the philosophy of what we learned from day one as osteopathic medical students and what we carry through our careers really prepares osteopathic physicians to practice in value-based environments, because we've always been taught to really look at a little bit more than just what's black and white in front of us. So, and I wasn't sure exactly who all my audience was going to be, so I apologize if any of this seems sort of quote unquote dumbed down and sort of like, well, duh, of course we know that, we're practicing physicians or whatnot. But as a comparison of what fee-for-service medicine is versus value-based care, we all know fee-for-service, it's the standard, right? It's I do something, I submit a bill for it, I wait 3, 4, 6 months and hope I get paid for it, right? Based on my contract. What that does is it can result in inflations of prices. It can lead to really no rewards for the quality of care. It doesn't really matter how good of a job I did on that office visit with that patient. It doesn't matter if I did a better job than Dr. Smith across the hall. If we both submit that bill, we both get paid the same regardless. It doesn't matter if I spent a half hour and they spent 5 minutes. If we both submit the same E&M code, we both get paid the same. That also can result in redundancy of care, which I think is probably one of the most critical things that happens in a fee-for-service environment, is if there's no incentive to really keep track of, did my patient already have this study? Did they already have that done? And everybody's just ordering and doing it. Are we really expecting the patient to keep track of that stuff, or is the onus on us? And yes, electronic medical records and the cross information that we get in those health records is supposed to cut down on some of those things. But I don't know, in my experience, I'm not sure it's really hit that on the mark. We're still doing a lot of redundant care. We're still doing a lot of duplication of things, and probably some unnecessary testing and unnecessary utilization. So in value-based care, on the opposite, again, about the quality over the quantity, and that's trying to bring better care for the individual at a lower cost. And often, and studies have shown, there's typically better satisfaction on the patient end, and often there can even be better outcomes, whether it be hospitalizations, readmissions, length of stay during admissions, better ability to meet marks as far as getting preventive care done, things of those nature. And that's because there's an incentive for the physician to practice at their full scope and with their full arsenal of what they need to do for a patient to keep them well. So that's just a basic premise of it. And when you really look at a deeper definition, a value-based model requires providers to be more efficient and more strategic with the care they offer during the patient visit. It really rewards you for diving deeper into the problems, the social demographic factors, instead of just running tests and ordering medications, right? So again, really lends to, I believe, the philosophy of what we learned early in our osteopathic training. You got to dig a little deeper. You got to really look at the patient before you just start sending and doing. And so that doctor-patient experience becomes a little less transactional and more personal. Those consultations can be spent more with really looking at a holistic patient experience when you're sitting in that room, really going over all of that. And I think that's what really strikes me and has really resonated with me in doing this model of medicine for the past 15 years. I love to talk. I love to talk to patients. It's quite honestly why I went into medicine. It wasn't just to order tests. It was to be with the patient, talk to the patient, put my hands on a patient, comfort a patient. And I'm afforded that opportunity because I have a little bit more time to do that. But in the end, I truly believe it shows us what's given better care to my patients. So CMS has really led the innovation. That the value-based care models in some iteration have been around for some time. It's just really certainly on the upswing right now. When you talk about lots of different terminology, alternative payment models, advanced payment models, there's many different words and terminology that are used. Currently, value-based care is sort of the buzz way of really encapsulating all of those different types of models. Now the private insurance industry has also implemented, obviously, their higher levels of payment model changes based on many of the things that CMS has already done. And it was reported in December of just 2021 that over 40% of healthcare payments for 80% of covered people out there were made under some form of an alternative payment model. And you'll see as we get into some of them, not all of them are 100% on that, but there could be some portion of that. So again, those alternative payment models usually come with a quality factor, not a quantity factor. And as with everything, and who knows how long we'll keep saying this, COVID certainly really brought this to the forefront, because for people like myself who were in a value-based care model, we were blessed. I mean, when COVID hit and we couldn't see patients, it didn't affect us nearly as much as those who were completely reliant on a fee-for-service model, where if they couldn't see a patient, they couldn't bill, they couldn't keep their doors open. So Medicare, CMS, Medicare Advantage, they have their plans tied to almost 60% of their healthcare payments are in these types of plans as of 2020. And across all commercial insurances, because as I talk about later, Medicare and Medicaid basically contracts with these commercial insurances to provide these types of value-based programs, and they're just rising year after year. They're expanding and expanding. So it's not really something I think we can get away from, and I think it's something we really need to embrace. And so what is the ongoing CMS plan? Again, it's to continue proliferating this type of payment model. And they've done tons of pilot models, and that wasn't the stretch of this to go into all of that. But I think it's also come to the forefront that health equity has to be a part of this. Again, COVID brought that to the forefront. Many other things in our country and our environment are just showing that the equity of our care is just not existent in many areas for many reasons, and that has to be addressed. These models are designed to favor provider participation. Sometimes it has some downside risks, which we'll go into, but often it has actually more positives usually for the providers, and hence why it's becoming a more popular thing on the provider side. Medicare obviously wants this strategy to expand to almost all Medicare beneficiaries, but it's also expanding into the Medicaid programs as well, which obviously relies on working with their states and their communities to make those things happen. And really, I think as it stands now, and we all are probably aware that when I say as it stands now, because just like we're all aware that CMS is part of government, as the government changes, things also change. But certainly the pendulum is swinging right now from going away from fee-for-service and trying to get to other forms of payment models similar to what we see here. And so here, this is the general, consensus for CMS is that they would really like to have all of their Medicare fee-for-service converted to accountable care, value-based care programs by 2030. So in that, with the growth of our population, that is a significant sector of the healthcare industry. So I'll go in a little bit, and I'll try not to bore with too many details, but there are different types of value-based care. It's not a one encompassing thing. Here's just some of those. I think some of this terminology everybody's probably heard of: patient-centered medical homes, accountable care organizations, and then we'll get into some other things called bundles and shared risks and savings and capitation. So patient-centered medical home, I mean, just saying those words in one sentence, I don't think there's anything else that could encapsulate anything more than, as a primary care family physician who's osteopathically trained, that doesn't just like ring of like, wow, that just sounds perfect, right? Because that's why I do what I do. That's what I've trained what I do. And so what does that really mean? And I would love to say that ACOFP had this definition on their website, but I actually stole this from AAFP because I just thought it would really honed in on what it was. And, the key functions of a medical home is to provide access and continuity, to be able to plan care, preventative care, and look at population health, and do that through technology and the means of what we have to be able to manage chronic conditions. Care management, it requires much more than just us as the singular physician. We need to be working in teams to be able to really truly support our patients and to make sure they get the services that they need. We have to engage the caregivers and the patients to be a part of this in that shared decision making, because if we're not, we can keep telling people what to do, but if they don't feel like they're part of the plan, getting them to do it makes it much more difficult. And being comprehensive and coordinating care, building relationships not only with your patient, but with your providers, with your networks, with your community, and with everybody who does that. So, I mean, I think, right, that's like a utopia, right? Isn't this would be the perfect way to take care of patients. This makes perfect sense. So it's just sometimes not so easy to do in certain confines, in certain contracts, and in certain areas. So how do people become recognized as a patient-centered medical home? Well, the NCQA, they're the biggest ones for recognizing that. And there's more than 10,000 practices with over 50,000 physicians who are recognized as patient-centered medical homes. Multiple organizations support that being like the gold standard, that if they believe you meet those measures and you are, then you are. There's other entities that can accredit someone to say they're a patient-centered medical home, but attaining that title of a PCMH, a patient-centered medical home, means you are doing those things, and that there can be incentive payments tied into that based on the fact that if you're doing those things, you're providing more quality care. And then you get into accountable care organizations. Often people who are working a patient-centered medical home are part of an accountable care organization. They work with other doctors who are also at that level. They work with hospitals, they work with imaging centers, they work with skilled nursing facilities. They build sort of this network that's all focusing on trying to deliver high quality care and reducing the spend on healthcare dollars. And it works well with Medicare beneficiaries and all working together. And when an ACO works well together, and here's just a good demographic. I mean, all of these could be involved in an ACO. And so where does that put us? Well, as you know, the primary care, family physician, or internist, or whatever, you're obviously there right in the center, and it's everybody else around you that you're working with to try to make sure that you're doing what is best for the patient. In essence, in my particular practice, I am not part of an accountable care organization. We are the last type that I'm talking about. Basically, what you see here is basically what I do on an everyday basis. My group, we round in the nursing homes, we round at the hospital. We have a very specific DME supplier. We have a care management team. We have a handful of home health agencies that we work with. We have our network of specialists. So we kind of know exactly where all the care for our patients is going and have a way to keep track of those things to make sure they're getting what they need to have done. Bundle payments are a little bit unique. They usually focus a little bit more around hospital-based things, surgical procedures, things of that nature. They're not really so in line with just basic outpatient primary care, and I sort of focus more on that. But just for completeness, wanted to mention that it is a form of value-based care, really getting a bundle payment for a transactional case of care. So something that might be a 90-day clinical episode, like a surgical procedure. They might say, well, we're going to give you X amount of dollars for that, and you need to do whatever it takes to take care of the patient in that time frame. If you do a great job and take good care of the patient, it might mean that you actually make some money on it. If you do a bad job of coordinating their home health care and their wound care visits and their physical therapy and all of that, and they don't have a good outcome, and they get readmitted at the hospital, guess what? You don't get paid more for that. You still have to pay for it out of that bundle. So the incentive is to do things the right way and take good care of patients from the beginning. So these are just some of the things that fall under certain bundles. Again, they're things that tend to be more hospital level diagnoses or procedural diagnoses. So some orthopedic procedures, spinal procedures, things of that nature. Again, working within those diagnoses. So again, not so much from a primary standpoint, but could be involved from a primary standpoint, as we are many times. I deal with a geriatric population, so I consistently have people that I'm seeing after their total knee replacements and after their hip fractures. And what can we do in our office to make that? Well, certainly, OMT is one of those things. Like, what do we do to get people moving and mobilizing better and reducing all of the other potential post-op complications? Those are the things we can provide to the mix to prevent some of those other things from happening. Shared savings model is, again, something that's sort of an agreement that can happen with ACOs. They differ from a fee for service. In fact, that the payer reimburses the provider based on the agreement you've come to terms with about quality and spending targets. So if the targets are met and savings have been had, then the providers are paid some bonus, so to speak, or the incentive payment from the payer. If not, then there's no penalty occurred on the provider. So it's all an upside, and there's no downside risk, so to speak. So it's all only the positives, but then again, you may not have the positives, and then you don't share in any of that. So this is something. There are different tracks that all run through Medicare that work with ACOs in these shared savings types of plans. And you can see there's a number. This was just one I pulled from the site here from 2022 off of CMS, that there's over 480 shared savings programs and ACOs. And you can see where there are definitely areas of the country. I am from Florida, by the way. I didn't mention that, I think, at the beginning. I live in one of the meccas. It's, the Southeast and the Northeast tend to be the areas where these are very much more notable. So, but definitely they are increasing and becoming more popular. And as you see, covering over 11 million beneficiaries. Shared risk on the other side, risk implies there is risk, which means you may benefit in the rewards if there's savings, but then on the opposite, if the spend is greater than the target and there's a loss, then the provider must also sometimes take a part of that loss. So again, it's all about that incentive to keep doing the right things. And I often get questions on, especially when I go into my very specific model of, well, gosh, like that risk of it, like that's just too much to consider, right? And I often, whether I'm teaching my students, residents, or whatever, is that, again, at the end of the day, I feel like 99% of the day when I go in and I see a patient, what I'm doing for that patient is not in the mindset of necessarily like, oh, am I saving money today? It's in what am I doing to provide the best care for the patient that day? And if that's always in the forefront, that usually is what's going to end up being the right thing to do for the patient and saving money by the way. Doing good preventive care, again, taking good histories, figuring out what are the real problems that are going on with that patient, and not just kind of referring them out to 16 different places and hoping it all sort of comes together, really trying to get down to the bottom of what's happening. And then the final one is global capitation, and that's the model that I work in. And global capitation is the riskiest side, so to speak, of value-based care, because it's at the very end of the spectrum. It is 100% that we are assuming the quote-unquote risk of the patient. Really, this designates a certain amount per patient for providers based on the patient and their health. And out of that amount that we get paid, we pay for all the care for that patient. So basically a lot of these plans work through Medicare Advantage plans, because again, this is a CMS plan, and it's contracted through a payer. So I deal with Humana. And so I, in my practice, have 1,600 Humana Medicare Advantage patients. And I don't practice by myself. We have 6 providers to do that, which that should already ring a bell for anybody. Like, we have 1,600 patients and have 6 providers. There aren't many family medicine offices where you would have 6 providers for only 1,600 patients. But again, the whole point is we have to take really good care of our patients. And so we do that by having more time and being available and being able to cover the hospital and the nursing homes and all those things, full scope. What we do is we get those 1,600 patients times the calculation based on their socio-demographic and their medical conditions, and that's a value to Medicare. And then they give us so much money for that. And then these are millions of dollars. But then, of course, we pay out all their hospital bills and their pharmacy and their specialists and their radiology bills. And then basically what's left at the end is the savings, or that's what our practice makes. Again, there can be times where it could be the negative. I can say in the 15 years I've been in our practice, we've only had 3 months that we've ever been in the negative. And there's protections in place for that. It's really not meant to be a punitive thing. It is meant to be a positive thing. And for the patient side of things, a lot of times when they're in these plans, it's really great for them. Again, in Florida, we just have tons of these. The options are endless. But it's much better than their traditional Medicare. They get more than their traditional Medicare, and it replaces their Medicare. So on the patient end of things, besides the care they get from us, the comprehensiveness of the plan, the drug coverage, the other benefits, the wellness programs, the vision, the dental, the gym memberships, the home health, the whole package is kind of something that they don't get with just straight Medicare. And as I was on, this is like the Medicare risk adjustment. That's really like how the payment happens. So obviously the sicker the patient, you know, when you have I think I put examples in here. So, you know, if you have Philip, who's 88 years old and has lung cancer and diabetes and all these issues, clearly he's a more expensive patient to take care of, right? And there's these fancy calculations, and that's not the purpose of this, but to give an example, so Phil we might get paid $2,400 a month to take care of Phil, but if Phil ends up in the hospital next month and it's a $15,000 bill, we have to pay that bill, and we pay for all his medicines, and we pay for his oxygen, and we pay for those things that comes out of that payment. So what does that mean on our end? Well, it means two things. One, we need to make sure we capture the complexity of what it is in his diagnosis. And again, it comes down to we provide the best quality care we can. And there's always, we all have had patients, right, who aren't going to do what we ask them to do. If everybody did everything they were supposed to do, some of us might be out of jobs. But so that doesn't get factored in. I mean, it doesn't matter if they don't want to do it. It's still kind of on us to be but that's sort of how it is with everything. You know, we have to be the ones who are educating and supporting and trying to guide our patients to the best possible care for themselves. And then as a flip side example I just gave, so here would be Maria, who's much younger, 65, and still has rheumatoid arthritis, but is otherwise pretty healthy. So she's kind of a lot lower on that. So you see her total unadjusted would only be like $580 roughly. So, you know, there is the adjustment. It's not like just a one-time payment for every patient, because clearly not every patient requires the same to take care of them. I have many patients who come in and see me once every 6 months. They're perfectly healthy. They're never in the hospital. And then I have the ones just like every primary care physician would have, who could be there literally every 2 weeks, and it's still very hard for me to keep them well, but we do what we have to do to try. So on my end of things, sort of when I said at the beginning, what was important to me is being in this practice model that I've practiced for 15 years, my patient volume in a day is not that of a typical family physician. And I can see how people could say there's a pro and con. Well, that's great for you, Nicole, because you only have to see 8 patients a day, but what about all the patients who need to be seen, like in your community or whatever? And so I am sensitive to that. I think if we were all practicing in these types of models, that would start to self-correct itself, because we would be taking better care of patients. We would be utilizing care in the right ways instead of lots of visits that sometimes are not as meaningful or as productive. So my interactions with patients are a minimum of 30 to 45 minutes. When they are there that day, if they need the use of the skills that I've been trained to do, which does include OMT. I have a number of patients I see on a regular basis for OMT visits. I have those that we do it just because it's the appropriate thing to do that day when they're there. I do a ton of dermatologic procedures. I still do GYN visits. I do all of our injections. And as I've mentioned, us as a group, we take care of our hospital patients and our skilled nursing patients. So I feel fortunate that where I am in my career, that I really, truly am using everything I've been trained to do. And I did work in a fee-for-service practice in the Philadelphia area for 3 years before I moved to Florida. And I did not feel like I was able to do that. I felt like I was just trying to see patients as fast as I could to get to the next patient. And I would look at their insurance first before I'd look at the patient. So I had a mindset of what I was going to be able to do with the patient that day. And that very early in my career started to be like, oh my goodness, like I'm never going to have time to do, you know, OMT or derm or gynecologic visits, because I'm trying to keep up seeing 25 patients a day. And so for me, this has just been something that's been much more rewarding than ever any of my past experience. I feel like I've obtained a better understanding of the healthcare system as a whole, just how some of that really works and what the cost of things are in our healthcare system that are just mind-blowing. To think, you know, what things are costs or are paid to certain entities when you think about as providers, and particularly those in primary care who seem to fight to be paid equitably. There's definitely a lot more autonomy in my patient care decision-making. I don't need authorization from insurance companies to do anything. If I want an MRI on a patient, I order an MRI on a patient. If I want to send them to the cardiologist, I send them to the cardiologist. You know, I don't need approval, because again, I'm the one managing the care to do what I think is best for the patient. certainly less paperwork, still have to do my charts, still have to do all that, but not all the authorization stuff. If there's very few things, I'd probably say like twice a month I get like a pharmacy authorization or something, but it's not like a daily thing. And overall, it's been financially rewarding. I certainly have a good work-life balance and have managed to do very well and love what I do every day, which I think is critically important. So when I look at that and I think, well, okay, so how does OMT and osteopathic principles fit into these models? And so I've probably said it a few times, but when the basic premise is reduction of costly care and an increase in quality care, I think it's everywhere, because again, that's sort of where we've been, much of our early training is, and just our general approach, and even more specifically like OMT. So when I'm providing care in my capitated model as this, my goal is to keep patients healthier and not to utilize more expensive mechanisms of care. I don't want them to go to the emergency room for low back pain. I don't want them to have to, think that they need to go see a chiropractor or somebody else. Like I want to be able to do that for them in my office. So that's just one mechanism of what we do on some of that. I work in a practice of all DOs except for my husband. He's the only MD, but I say he's the most osteopathic MD I know. So we all kind of utilize that. We all know, I'm speaking to the choir here, but using our hands is extremely cost effective and it provides good outcomes, right? I don't need to tell you all that. And sometimes, and I've unfortunately heard, or when I've worked with residents or even students, there's this misconception that you can only do OMT if you're like an OMM, NMM specialized person. I'm like, oh, heck no. Like we do that in family medicine all the time, but the models of family medicine sometimes preclude people from feeling that they can really incorporate that really well in their practice because it might take too much time, or they don't know how to bill for it or whatever. But there's just no better way to really have that connection with the patient than getting your hands on them and making them realize that when they leave there that day, they have gratification that you helped their pain and that they feel better. And probably, not that it particularly bothers me because I still really enjoy the aspects of billing and coding as well, but I really don't have to worry about that in my model. Again, since everything is capitated, I'm not billing out for my services every day. So it doesn't matter if I do OMT or do a injection on someone's knee or do a dermatologic procedure. I don't get paid more to do those things. It's kind of like the reverse. I do those things, so I'm not paying someone else to do those things. So I don't really have to worry about the specifics of billing my OMT visits, which for sometimes seems, I've heard, sometimes seems like it's a hurdle, even though it's really not that problematic. But the whole purpose of why I do it is for the purpose of the treatment and making someone feel better, not because I'm getting paid to do it. And so it's kind of that reverse fee for service mentality. So I think that's what makes it even more enjoyable, is because I don't have to feel like the pressure of doing it and do I have time to bill it and code it. I'm doing it because it's what's appropriate. So I think that's what's really allowed me to utilize a little bit more. Obviously, I'm in a Medicare-based group, so we all know can be some limitations that, my 85-year-olds, sometimes don't do nearly as much on, but there's always situations of things where we can incorporate that. So that's been very gratifying for me, especially since I teach osteopathic medical students. It's been great to show them how you can incorporate that in your day-to-day as a family physician. And then again, just our overall principles, like, DOs still lead in the percentage of providing primary care. I mean, we do. That's still our bread and butter of what we do, and we do it better than anybody else. In my leadership positions as the president of American College of Osteopathic Family Physicians, we've had numerous meetings with the leaders of the AAFP, and they always marveled at how do you guys get 20 to 25% of your students to go into family medicine every year when the allopathic profession only gets roughly like 8%. They just don't know how we do it. And I'm like, well, it kind of starts from day one. It's sort of what we're kind of, a big part of who we are and what we do. And as I said at the beginning, our tenets just really seem to me in many ways parallel to what the quadruple aim is and value-based care, and that these models really can be successful when the motivation at the end of the day is better care for patients as a person and not as a number. We're not just looking to try to move people through and check the boxes and get RVUs. We're really trying to keep patients healthier and better. So those are sort of things. So what do I think we can do like going forward? And I would even maybe look to some on this group. You know, I think the best thing we can do is we continue to do research and expand about how OMT has positive outcomes, because that's always, you know, it's always about, well, what does that do to prevent that? And how does that correlate to cost savings? Certainly, I don't have 100%. I don't have statistics on that, but I could just tell you, like, one very particular patient comes to mind. I see her every 2 weeks. I've been doing it for probably four years at this point. We've avoided surgery. She's never once gone to the hospital or the ER for her low back pain. She's not on narcotics. She's, you know, not on that. So to me, like, that's a surmountable cost savings and good care for the patient, because I'm able to provide that. And then also just how do we continue some adaptability of our techniques and our modalities to, if the population that a lot of these value-based care models are Medicare aged at this point, you know, what are some things that we can do to continue to do that? When I teach my students and I show them, I said, you know, when we get taught our initial OMT, you know, we're typically working on our fellow students who are, you know, 25 and spry and can jump up on the table and do whatever. I can't, my 80-year-olds don't jump up on the table all the time quite so spryly. So how do I have to adapt some of my techniques and stuff? So you kind of learn like tricks and ways you can get things done, but do it in different ways. So I think those are definitely things that we continue as a profession to keep doing and showing just those modalities. And as you're all probably aware, the allopathic physicians are just clamoring at wanting to know how to do osteopathic manipulative therapy, because they're having patients ask for it and they want to know what our secret sauce is. So we need to keep being the people who push forward with that. Again, and then we just continue, I think, a lot of our emphasis on primary care being the central role that really is needed in value-based care. And as the population is aging, obviously, we're going to need more and more of that. And then, which is near and dear to my heart as part of my thing, I have my business degree as well, you know, not being afraid of these alternative payment models, not being afraid of other avenues, and really getting that information out, that especially with our students, to kind of dispel those preconceived notions that being a general internist or a family physician, that there's kind of like no way to be able to repay your loans or have a good career or have a good life. I tell my students all the time, I don't really know many out of work physicians. I mean, if they are, it's probably voluntarily or they've done something really, really stupid. But otherwise, like, we're always needed, and there's plenty of great opportunities out there, and it's a great profession top to bottom. So I think continuing to do that. And I think certainly some of the national organizations and state organizations that I've been a role of, certainly the second two are big primary things that we keep focusing on. So we keep getting more and more students wanting to go into primary care. So I talk kind of fast, I'm sorry. But that was generally what I wanted to be able to present, to be able to leave a few minutes for anybody who has any questions or comments or concerns. And I just appreciate your time and attention for this Friday afternoon here. So thank you.
Dr. Bixler, that was a really great presentation. Thank you so much for that.
You're welcome.
Dr. Degenhart, did you have any comments or questions that you wanted to ask before we get started with other discussions? And while he's unmuting, Dr. Bixler, I didn't know if you saw while you were presenting, we had a really robust conversation happening in the comments section. It was really wonderful.
Because I was trying to stay focused. So I did not open up my chat box. Otherwise I get a little like, you know, like, ooh, shiny bird. So so yes, so I would have to catch up, but oh yeah, you guys did have a lot of stuff going on in there. So
yeah, it was really great. It was a really great conversation. So just to get us started, well, number one, if you guys have questions and you would like us to ask it, go ahead and put it in the chat and I'll ask it for you, or just raise your hand and I'll unmute you so you can ask your question. But I just want to ask the question as kind of a side question,
Sure.
And I apologize, I'm not a content expert, but my question is, all of these care models seem sort of, they really require a lot of interprofessional work. And I didn't know if you could speak to that, and those relationships and how important they are in establishing and maintaining, and how you do that with your care model.
Yeah, that's a great question. So yes, it does require that. And even though I said we're not in like a particular ACO per se, we do have a lot of, so just as an example, let's say, so when I do need to send a patient to my orthopedic surgeon, which, so in my model, if somebody comes in with knee pain, I don't just say like, okay, let's have you go to the orthopedic doctor. I'm going to, besides doing the initial evaluation, I'm going to try corticosteroids. I'm going to try therapy if OMT is appropriate. I'm going to do all the imaging. I might do Hyalgan shots. Even 2 of our doctors do PRP. We do everything we can do so that when we do send the orthopedic doctor, he knows that when he gets our patient, like we've already done all that. Like he's not going to reinvent the wheel. It means if I'm sending my patient to you, it means they need the one thing I can't do, and that's they need a knee replacement probably. This is just a very simplified example. But after working with that provider for 15 years, he understands what our model is because we've had those discussions. Like we say, you know, we'll use you pretty much exclusively if like you're not going to try to always reinvent everything we've already done. I don't want you to start over with steroid shots and Hyalgan shots and all those things. You have to trust the fact that we've done those things and they don't work. And so we've built a really great relationship with a number of our specialists in that manner. Another example is, these might seem like small things, but they end up being, lots of small things end up being big. So bread and butter, as a family physician, I advise people all the time when they're due for their screening colonoscopies, right? That's just routine preventive care. So our one GI doctor I work with, if I'm seeing a patient, we're doing a routine screening colonoscopy, he allows us just to set up directly with him at the endoscopy center where he'll just meet the patient that morning. We do all the prep and everything and all the instructions, and he'll do the scope. And if the scope is fine, he just sends us the results. So what does that do? That means that my patient doesn't have to go to his office first to pay a copay, to see him for 5 minutes for him to say, you're right, Dr. Bixler's correct. You are due for your screening colonoscopy. Let's now get you scheduled. Then see him for the scope. And then when he gets the results, have the patient come back again for another appointment where they have to pay a copay again, and him say, your colonoscopy looked fine. You had diverticulosis and you need to do it again in 10 years. So after working with this doctor, you know, we've come to this agreement where I can do the pre and the post. I just can't do what's in the middle. Well, I mean, I guess I could if I learned how to, but in my environment, I don't, but some doctors do, but not me. So what does that save the patient? It saves them 3 visits for what they really only needed was what's in the middle. It saves them 2 co-pays for a specialist. So currently that saves them $50 and scheduling and getting there. But it saves my practice the $150 we would have paid for that specialist visit and the $100. So it saves us like $250. But that didn't just come about because that came about with having some discussions and kind of saying, hey, and you know, at the end of the day, the GI doc makes money for the procedure. Like they do the other things, they make some money. Because like he goes, if you send me most of your scopes, I don't need to do those things because I'm like, we're working with a really good relationship that I know you're sending me like 95% of your scopes, right? So we do a lot of that stuff. It does take some time. There are some specialists we don't have quite as good of those things, but for the most part, you know, a lot of times if you explain what it is and what you're doing and they realize at the end of the day that you're a good doctor doing the right thing and you're not doing it about restricting care, because that's always like the one downfall that people say, well, in this model, you could always restrict care. Restricting care never does anybody any good. So that's not what it's about. It's just about being better at utilizing care and doing what's better for the patient. So it does require a lot of that. It does require some legwork, but once it's kind of set, it's pretty good to go. So good question.
Thank you, Dr. Bixler. I appreciate that. We have 2 questions, 2 hands raised, and then we have a question in the chat. So we're going to start with Dr. Brooks. If you want to go ahead and unmute Dr. Brooks and ask your question.
I don't so much have a question, but a comment. So I think I'd quarrel with you a little bit about your love of Medicare Advantage, but in the context of your capitated plan, it seems to work really well for investment for your patients. But what I want to comment about is we've had other presentations in DO-Touch.NET that have pointed out that the cost of caring for people with cervical and lumbar pain in the United States far exceeds that of cancer and heart disease. I mean, that is literally where the money is. And we would hope, given our affection for OMT, that we could reduce that cost.
Mhm.
There is a perception, correct or incorrect, I think, amongst our younger generation that, quote, you can't get paid for doing OMT, close quote.
Right.
And that might be incorrect, actually, if people would really take the time to look into it.
Mhm.
I years ago, I'm in the latter stages of my career, but for a while I worked at the University of Arizona as a faculty member in orthopedic surgery, providing non-operative care. And had I stayed there longer, one of my ambitions was to go head to head with the surgeons and show that we could reduce the cost of care. And a lot of it has to do with risk reduction. So I'd like to suggest to the research community that we start focusing on risk reduction.
Mhm.
Because if we start talking about cost reduction, then that might mean you don't pay as much for OMT either. And that disincentivizes the next generation from practicing. If we could reduce the risk of ionizing radiation and injections and surgeries and the complications thereof, then we could justify actually paying more for the tertiary care, tertiary preventive care that we do with OMT. So that's my comment. Thank you for a wonderful presentation.
Thank you. And you are very correct on that about the cost of cervical and lumbar disease, particularly with what you mentioned, once it goes to surgery. The way that those diagnoses and those diagnostic related group codes or bundles are for hospital level care, the highest cost of a surgical procedure, surgical care episode is a lumbar laminectomy, cervical, anything that's surgical on the spine. That's a minimum of a patient for us in our current payment. Any patient who has anything surgery done to cervical and lumbar, that's a minimum of a $30,000 hospitalization. They can get a cabbage procedure cheaper than that. So you are correct. There's no doubt. So precisely what you said, it's about how do you keep it non-operative and how do you prevent it from getting to that point? Because I think that's where the real, not only cost reduction, but risk reduction, right? Because certainly doing surgery on the cervical or lumbar spine doesn't come without its share of risks. So you're absolutely correct. Thank you.
Okay, Dr. Dean, I believe you were next. And then we have a few questions in the chat, Dr.
Sure.
Robbins, and then we'll get to your question too. Okay, go ahead, Dr. Dean.
I think Dr. Degenhart kind of was thinking along the same lines. I know you mentioned that the alternative payment model in your slide was for primary care, but I wondered if there are alternative payment models for OMM, and also if anybody on the chat has any ideas. So I'm part of a hospital-based OMM department, which is volume-based, and the department never makes as much as the hospital wants because our procedures are 30 minutes long, and we bill an E&M code and we bill a 25 modifier and an OMM. But I just wondered, are there value-based models that actually bring in more income for OMM as a specialty? And if there are value-based models for, like Dr. Degenhart was saying, for OMM, I guess.
Right. So, and touching base, because I see the question that Dr. Degenhart posted. So like, all I can say, like, so currently, like in my particular model, let's say I was not a DO who used my OMT skills, but I thought that I could use the services of someone like yourself. I could certainly refer my patient to you, and then my group would just be paying you like any other specialist. So that would still, like, that would obviously be beyond the outpatient standpoint of things. You are correct in what I saw there, like in the hospital model. You're right in one sense that some of it could get bundled into a certain payment, but typically the physician who provides the service can typically bill, depends if you're working for the hospital or you're not working for the hospital, but then bill for your particular service outside of that. So whether a physician who really just purely focuses mostly on OMM and MMM, I don't know if currently there's a value-based model that would specifically be able to incorporate all that. I think where the value would be working within an accountable care organization or in conjunction with, like, almost to say like my practice model, but having someone like you in my practice model where that's your part of our practice model and that you're the go-to for that because you're the the guru in that more so than the rest of us. But at the end of the day, we all share in the same savings, the same amount. So I think that's more where it would be versus in and of itself as its own entity, because there's so many more things you have to do to be in a value-based model that you would have to do all the other stuff too. So hopefully that answers it a little bit. So
That's helpful. Thanks.
Yep.
Dr. Bixler, to this particular topic, Dr. Degenhart asked, would the OMT provider bill the PCP practice?
It would bill the PCP practice, correct? Yeah. If I was, well, it doesn't actually get billed to the PCP practice in my particular model. You would still bill Humana. You would actually get, that's kind of the other part that's a little bit, the specialists I refer to, I mean, they don't get a direct payment from me. They still get a payment from Humana. But then our practice is the one that then gets quote unquote billed from Humana for all the stuff we sent out. Like every month we get a report. Like I get literally an 800-page report every month that tells me every claim we've paid out for every provider, medication, hospitalization, and exactly what we paid those providers. So I could see, again, the value would be having like a PCP who feels that that is something that helps reduce other more expensive procedures or seeing the orthopedic physician or whatever. And therefore you become someone I refer to because I realize your outcomes are better and in the long run do better for my patient. And so that makes you someone valuable in my overall model. But then you would actually get paid directly by Humana in mine, because that's what I take, or whether it was Optum or whoever the PCP was working in that value-based managed care model. So hopefully I answered that correctly.
Thank you, Dr. Bixler. So we have about 4 minutes left and we have 2 questions in chat, and Dr. Robbins also has a question as well. So I'm going to try to ask these quickly. So Dr. Zamore would like to know, what are some resources to begin the education of alternative payment and work models?
Right. So I put a few at the end here. So honestly, going to cms.gov, they go through a lot of this information. AFP, we even have some of them on ACOFP, but I'm going to just be flat out honest. AFP has bigger, better resources than we do. So they have more on theirs because they have a little bit. Those are 2 like to start with. I can also tell you that traditionally, at least I can speak on behalf of ACOFP, and even I know from the state of Florida, I mean, we kind of incorporate at least 1 or 2 lectures generally on these types of things in almost every convention that we do now. So I was just at our Florida one, and one of my cohorts, she did one on, again, alternative payment models. So I think too, just that. And then honestly, I think truthfully, the best way to learn about it is you got to talk to someone who does it. Because it can just like we do in medicine, a lot of it can be alphabet soup, and you just start looking at all this, it can get very confusing. So I think the best thing is finding someone who does it and just kind of tapping their brain and saying kind of the pros and cons and how does it work and how can I find that in my area. So you'd be surprised how many people work in those models, and you may not even realize they're working in those models. They're not like something you put on a like neon sign, like, oh, this is a value-based care. I mean, as far as the patients know, they just come to a really good doctor and like our practice. So.
That's great. Thank you so much. So we have another question in the chat. It's from Dr. Warden, and she says, I remember capitation in the 80s and 90s. You got paid $5 per member per month, no matter how much they saw you and how frequently they wanted OMT. That is $90 a year, hardly enough to cover 1 yearly physical, and it did not work well. Is the capitation amount better now?
Oh, it's 100% better. So those 2 examples I showed you. So I'll just give you some like real life numbers for the most part. So I told you 1,600 patients in my practice based on the cumulative, what's called MRA score of our practice, which roughly right now is about a 1.7, which is derived from all of their individual medical conditions averaged out. We get paid roughly $1,000 per month times our MRA score times the amount of patients. So we're getting millions of dollars per month. But of course, then we're paying out a lot per month as well. But it is not even remotely like what you're referring to of like the typical HMO capitation of being like the PCP, and I just take this group of patients and I'm only going to get paid X amount of dollars. These are much, much, much bigger numbers than that. And again, though, ultimately it comes down to, it does take some work on the back end, you know, different than those other capitation models. Like it only works because we all do a really good job of trying to take good care of our patients, making those relationships, coding our things appropriately to make sure we're capturing the complexity of the patients, doing our hospital work, doing those things. So if you're not really willing to kind of do those things, then it's not going to be nearly successful. But overall, definitely much better financially and more successful, and definitely not like the ones in the 1980s. So, yeah.
Thank you, Dr. Bixler. We have about 1 minute left, but I do want to get Dr. Robbins' question in. Dr. Robbins, if you want to unmute, she's raised her hand for a while, so I want to make sure she gets her question in.
Thank you. I put my my questions or comments in the chat, just to simplify. Essentially saying that Dr. Mazzara and I, speaking to resource management and making it possible to be the specialists who do the direct billing, it is essential for us to work as a team, but also recognize that we are the resource for a lot of the general practitioners out there, the PCPs and primary care focused doctors, including OBGYN. So now I see the patients who are coming through post-cesarean, years later, other chronic pain conditions, and when it includes the GYN and the OB histories, it's important to just keep on working, as pelvic rehab is now considered one of the primary subspecialty focus points for our entire profession. There are PTs who specialize in this. We just need to keep on defining our niche as OMM providers to not get lost in all of the therapists and mid-levels who are taking on our practice otherwise. So that's part of my point. And for Dr. Brooks and Dr. D, making resource management, and as Dr. Degenhart also said, primary care referrals, and then we refer back, are the best utilization, as I've experienced, for our system, where it isn't only on primary care to have to do it all, but recognizing that as the specialist, Dr. Mazzara and I, as rehab doctors, can help a lot with guiding proper utilization and getting them to the mid-levels, who then return the patients to us with hopefully some treatment in place.
Okay. I did want to bring up, we've run over time, but I did want to bring up this comment and question from Uli, who's actually one of our members in Germany. And he says, in Germany, more and more insurance companies of the NHS cover a part of OMM treatment. Are there any models like this in the US? Also, greetings from Witten, and thank you.
Well, I mean, since I said in my particular model, I can do OMT, I don't bill specifically for it, but I certainly know a number of physicians that are colleagues of mine in Florida that the insurance definitely are covering OMM. It's just a matter, again, as what was brought up about whether or not you do it and you build it and you know how to work within that to make it a functional part of your practice. So I would defer to anybody else who has anything other comment about that.
Yes. Dr. Zamora, did you have a comment?
Yes, I did. Big things I think about with incorporation. Now, I'm an OBGYN, by the way, who is very active in practicing OMT in every aspect of my practice. Back in 2005, when I started, there was no modifiers and there was no way to bill for it. So I'm like, wow, the tons of OMM that I literally did for free. Not that you're thinking about the money, but you do think back like, oh my goodness. And now, honestly, I was lucky to go to a residency that had an inpatient OMT department where I learned it and learned the value of it in postpartum and just took it further to the antepartum. But now moving forward, a lot of osteopathic programs don't have OBGYN that actually can do these techniques and work with them with the inpatient model. So they're not learning how to do this. I feel like managed care is basically, I feel like I have to go into do a DPC or another type of practice so I can perform what I'm doing and know what I'm doing with that population, because to be part of the managed care model, I'm going to be either a surgeon or a hospitalist, because that's what we're like the model for OB is kind of going to, and that's what the residents now are facing. So speaking to that with what you just talked to us about, it seems like a very difficult thing to separate in this field.
Yeah, I mean, I think you're correct. Maybe in certain, like, particularly like you said, for OB-GYN, that different because of the expectation when clearly looking at from a procedural standpoint, delivering a baby, doing gynecological procedures, things in the grand scheme of things are probably the bigger payers than OMT treatments, although we all know that on the back end of it, the OMT part can be very critical and again, the overall aim. So I think, and I'm hopeful, and maybe I'm naive, but I'm hopeful that as CMS has made this more of their initiative and realizing that the way we are doing things are not necessarily working, that this pendulum has to be swinging. And certainly for primary care, like family physicians and stuff who take care of such a breadth, that's obviously why it's where it started, but how can that be adapted to other specialties, right? And so I think you bring up a very good point, like why wouldn't that be perfectly adaptable? But then on the other hand, you are absolutely correct. I mean, even as family physicians getting trained, the level of what we're getting in as our OB care is drastically different than when I trained. And then the fear of how our future physicians being trained to see whether those things are applicable to their specialty and are they going to adapt those modalities to it. So it's definitely not easy. There's always going to be some hurdles, but I think having people like yourselves and others who are trying to think outside the box and figure out ways to make it happen. I think that, and you mentioned DPC, that's a whole nother aspect that is obviously a big wave of a different alternative payment model that is really born out of the fact that we're not doing it well enough in our current healthcare environment. So things have to change. And so people are finding ways to make them change. And hopefully the louder voices are going to prevail and things will continue to swing towards that way. So thank you.
Okay, we've run about 6 minutes over, but I did want to just end here with Dr. Brooks's comment. He had a comment. Did you want to ask that or make that, Dr. Brooks?
Sure. I just wanted to make sure that the audience didn't think I was focused just on the money when I suggested that risk reduction should be a language that we focus on. It's obviously better care for patients, and that's the most important thing too.
Absolutely.
And Dr. Bixler, are you in Spring Hill, Florida? Is that correct?
That is correct. Yes.
Okay, so your mailing address is, as I Googled it,
What 118 Seven Hills Drive in Spring Hill?
Yeah.
Yes, that's me. Yes.
Okay. I'm going to send you a book.
Okay. Thank you.
All right. Thank you.
Well, thank you all very much for joining us today, and we really appreciated your presentation, Nicole, and hope you will join us for other Let's Talk About OMM research episodes in the future. I know our next episode is the third Friday in September, and I can't think of the date off the top of my head, but
September 16th.
Thank you. Thank you. And that is a journal club episode, and Jenny Zamore is our facilitator for that episode. So we hope to see you then, and hope you all have a great weekend. And thank you.
Great.